So hopefully these slides work, because I had to convert them from Keynote to PowerPoint for anybody that uses a Mac, and hopefully I don't fall asleep. I spent last night in a fort with 4 kids and 2 dogs and surrounded by cushions, so it wasn't the best sleep. Anyways, so we're going to talk about lipids, and trying to keep it pretty quick. I think I have about 25, 30 minutes. And it's nice. I was walking around the booths, and there's no drug companies here that have anything to do with lipids, which is nice, because a lot of our CME is often sponsored by industry, and it really taints what gets said. So I'm going to say some things that may be a little bit controversial. I tend not to follow the Canadian lipid guidelines as closely as we'd be pushed to follow. And really my goal here is to kind of get us thinking a little bit about the evidence, similar to the last talk you guys just had. 3 questions I want people to be able to answer when it comes to dyslipidemia. First, who should we be treating? Second, if you've decided that you want to treat somebody, what's the therapeutic goal? Where do you want to get them as a target? And then lastly, how do we actually treat them? There's all sorts of different agents we have for treating dyslipidemia, and I want to go through a few trials. I'm not going to do a whole bunch of numbers, but a few trials just to highlight some points. So who to treat, first of all? I think it's fair to say we probably overtreat low-risk people, and some very high-risk people we tend to undertreat. But in the world of dyslipidemia, it tends to be more that we're overtreating low-risk people. Lots of trials that show that people who've had heart attacks end up on statins, these sorts of things. So I want to focus on those low-risk patients. There's really no debate in the literature when it comes to treating people for secondary prevention. So I don't want to spend a lot of time on that, but really good trials. You've had a myocardial infarct, you're a high-risk person going on to a statin therapy, there's good established benefit with pretty good numbers needed to treat. The primary prevention data, though, is way more mixed. And even the Canadian Cardiovascular Society guidelines really lay that out, but way more mixed than we think. And I think some of you will be surprised at some of the numbers. This is going to be a little bit hard to see, but this is data from 2006. It's BC provincial government data, and talks a little bit about what we spend in BC on dyslipidemia therapy, statins in particular. So in 2006, we spent $151 million in BC on statins. That's $38.43 per capita, every man, woman, child in the province. Pretty high numbers. When you look at the whole population, take 1,000 British Columbians, 72 per 1,000, or 7.2%, are on statins. So pretty utilized drug. Why do we care about that? I think as docs, we have a huge responsibility in looking after the system and making obviously good patient decisions, focusing on your patient, but looking at the economics of things as well. The cost for drugs, pretty dramatic, right? You think that $151 million on statins, in the whole province, we spent $131 million in the same year on all ophthalmology services, cataracts, all the stuff that they do. We spent $19 million that year on all internal medicine consults, general medicine consults. Your O100 code, we spent $234 million in that year on the O100, yet we spent $151 million on statins. $12 million that year on INR tests, $12 million on TSHs. Kind of puts it a little bit in perspective. Also, I think it's really important to understand benefits. So I was giving a talk earlier this week to a couple hundred patients on the North Shore just for a diabetes cardiac talk, and asked them the same question. I think I actually asked this question here last year. But would you take a drug every single day for 5 years if it reduced your chance of having a heart attack by 33%? Most people in the audience tend to put their hand up, say 33%, pretty good number. What if it lowered your chance from 3 to 2%? Way less people put their hand up. And what if you say it has a number needed to treat, or you've got to put 100 people on that drug to prevent one event? Way less people put their hand up. Well, all those 3 statements are exactly the same thing, right? So a drop from 3 to 2% is an absolute drop of 1%, or a number needed to treat of 100, but it's a 33% relative risk reduction. Of course, if you're talked to by somebody who's pushing a pharmaceutical, they're going to want to use the relative risk reduction number, right? The other thing that you have to think about with trials is real-world adherence to drugs is way different than what happens in a trial. Now, I'll ask my patients now, instead of saying, do you take your drug all the time, I'll say, do you take your drug like 5-6 days a week, or is it more like 3 or 4? Very few people will correct me and say, what do you mean? I take it 7 days a week. You know, most say, oh no, it's like 5 or 6. You know, so when you actually talk to your patients, the compliance is not nearly as good as we think. The other thing in trials is these composite endpoints. And I'll talk a little bit about that in a second. So primary prevention patient, you know, this is your patient who does not have established vascular disease, but may have major risk factors for vascular disease, including things that we used to label as, you know, risk equivalents like diabetes, would fit into the primary prevention group. So there's been epidemiologic data for a very long time that shows that your total cholesterol correlates in a very continuous and graded way with mortality and cardiovascular events. Now, showing that there's a link doesn't necessarily mean that changing that curve or intervening is going to produce an outcome, as we'll talk about. Lots of clinical trials, though, that show that when we do lower LDL cholesterol, we decrease cardiac events and mortality. The question is really how much. So I want to talk a little bit about WOSCOPS, which is the first large statin trial to show benefit in primary prevention. So don't get too hung up on the numbers, but this was a trial done in the West of Scotland coronary prevention trial. This is older. You know, a lot of these primary prevention trials were done in the 80s and 90s, and we haven't heard about them for a while. A lot of med students or residents that come through working with me, they've never heard of these, right? They're just not sort of new recent trials. But what these guys did, they took large number of patients and they put them onto a fixed dose of a statin, pravastatin, 40 milligrams once a day, or placebo, over 5 years. And they looked at the rate of MI and CHD death, and these were people who did not have established vascular disease. What's really important here too is the exclusion criteria. So these were all men, 45 to 64. If you were female, excluded. So women have not really been studied that well in statin trials. They showed they could reduce the risk of MI or CHD death. This is relative risk, remember, 31%, total mortality 22%. But if you drill into the numbers a little bit better, the estimated reduction in non-fatal MI or CHD death went from about 9.4% if you were on placebo to 6.4%, and it was a 5-year trial, but this was the 6-year data. So the absolute risk reduction, 3%. Now that's of any acute coronary syndrome non-fatal MI. So we had to put the number needed to treat would be about 33. So for every 100 patients that you put onto statin, pravastatin at 40, for 6 years, you prevented 3 coronary events. But if you actually look at mortality, the number needed to treat for actually preventing a death at the 5 to 6 year mark is 146 patients. Now, maybe that's a good number. You know, if I said all the men in the audience here, say there's about 140, I've got to put you all onto statin for 5 to 6 years. One of you is going to not die because I do that. You know, some of you will say, sure, put me on it. I want to do that for sure. Others will say, I'm not taking it for that. So it has to be very individualized, and the patients really have to understand these numbers. Benefit was seen early. The other thing that was interesting about this, it didn't matter where your LDL started. So I think a lot of us think, well, God, this person's LDL is 5 is really high. We got to get it down. This person's 3, oh, you know, not so bad. The actual LDL number didn't really matter. The people who had an LDL of 6 got the same benefit as the people who had an LDL of 3. This was a fixed dose trial, so everybody seemed to get the same benefit. And they think, well, why would that be? Maybe LDL itself isn't the problem. Maybe it's a surrogate marker, and when we put people onto a statin, we get some plaque stabilization or some pleiotropic effect, for lack of a better term. Kind of raises an interesting concept. Another primary prevention trial, ASCOT, the lipid lowering arm of the trial. So many of you will have patients like this, but this was a hypertension trial, but there was a lipid arm with it. Well done trial, 10,000 patients. They were randomized to either get placebo or atorvastatin. Everybody in this trial had hypertension, so they already had one risk. The age range was a little bit more broad than the previous trial, 40 to 79 years of age. There's women in this trial, although certainly more men. They had a mean LDL of 3.4, but these were high-risk people. So not only did you have to have hypertension, you had to have 3 other risk factors: LVH, diabetes, peripheral vascular disease, a previous stroke or TIA. They were smokers. They had to have a strong family history. There could be some ECG changes that got them into the trial. So they had to have 3 additional risk factors, including hypertension. These are kind of the really high-risk people, right? They showed that non-fatal MI and fatal coronary heart disease went from 9.4% to 6%. So there was a drop. Cardiac events dropped. Procedures dropped. Fatal and non-fatal stroke dropped. Yet with this, couldn't show any mortality benefit. So we prevented, or this atorvastatin in very high-risk people prevented some coronary events, did not change mortality. I think most of us would be kind of surprised to hear that, right? You think you take these high-risk people, you put them on a statin, we're going to prevent you from dying. That was not the case. And very interestingly, and this has been borne out in other trials, the people who got the least benefit were diabetics. In fact, they got hardly any benefit from going on to statin therapy, yet many of us would consider them the highest risk patients, right? Jupiter trial. I'm not going to spend a huge amount of time on this. This was big news a few years ago. This is the trial that looked at measuring CRP. So a well-done trial, 18,000 men and women. They had a normal LDL, but if they had a CRP that was greater than 2, they were then randomized to get either rosuvastatin at 20 milligrams a day or placebo. All the men in this trial had to be over 50, all the women over 60. So this doesn't apply to, a woman that's 52 or somebody that's outside of those age ranges. And they had a composite endpoint, non-fatal MI, non-fatal stroke, hospitalization for chest pain or unstable angina, revascularization, death from any cardiac cause. So they could show if you took those higher risk people with a CRP greater than 2 and you put them onto statin for 2 years, you could reduce that composite endpoint, not death, but that composite endpoint by about 44%. The number needed to treat, though, 82. So pretty high numbers. When you actually look at all-cause mortality, yes, you could take these higher risk people and relatively older people compared to some people that we treat and reduce mortality, but you had to put 182 people on a statin to reduce that risk. Maybe that's appropriate, but we got to decide with our patients what number is good for them. I don't want to go through all the tiny numbers on the screen. I know it's a bit hard to see. There have been some meta-analyses done. There's problems with the way that meta-analyses are done, but there's so many different lipid trials. And you have to remember, when a lot of the primary prevention trials were first done, the rules were very different. If you were a company that wanted to prove that your product worked, you might actually commission 2 or 3 studies at the same time. And the data was, of course, not for public consumption, but, well, trial number A showed benefit, so that's the one we're going to publish. Trial number B and C didn't show benefit, so we're not ever going to publish that. Trials now have to be laid out up front that they're going to be done, so if the data is negative, that data still comes out. But that's only been for the last 5 years or so. So negative trials just didn't get published. Anyway, so meta-analysis, a few years back now, 2010, just to give you a bit of an overview for primary prevention, 11 randomized trials, 65,000 people, couldn't show any reduction in mortality for primary prevention with statins. So mortality overall, relative risk 0.95, crosses the mean. They looked to be safe. There wasn't really change in serious adverse events. There was a reduction in CVD events, not mortality, but CVD events. But when you tease out 2 important groups, women, no benefit, certainly less benefit than men. And when you tease people out who are older, over 69, no benefit. So a lot of the trials haven't looked at that well. Really quick, just limitations with the lipid trials that have been done. It's kind of interesting. The Framingham group, so you guys all know about Framingham, when they actually look at the people in Framingham, which is the people that have determined how the risk calculators that we use work, right? I mean, that's where the statistics came from. They could show the people in Framingham, 40% of the men and 80% of the women fit criteria that have never been studied in statin trials. I mean, that kind of amazes you when you really hear that. 80% of the women in Framingham they would never have made it into any primary prevention trial, yet here we use Framingham to determine risk. I want to talk, just because I don't want to run out of time, I want to talk a little bit about the therapeutic goal. the Illuminate trial. So this looked at a drug nobody will have ever heard of because it never made it to market. But I think it's really important that you look at outcome, not on numbers. So this was a drug that raised HDL by 72%. It dropped LDL by 25%. This was going to be a really big blockbuster for Pfizer. They had a well-done trial, 7,500 patients. They had to stop the trial early. Those who got treatment and had their HDL go up and their LDL go down with treatment had a 60% increased risk of death, higher MI rate, higher cardiovascular death. So this made numbers better, but you died and had more heart attacks when you went on to it. So surrogate markers, and it was obviously pulled, surrogate markers don't predict outcome. I think it's also important just to know the cost of some of the things we do. A full lipid profile in BC, $21.31. An ApoB, $16.60. C-reactive proteins, $10.31. I'm going to talk really quickly about ApoB and LDL particles. I think we often think of LDL as a little cholesterol molecule floating around. I know patients do. It's not. LDL is a particle that your liver makes when you eat cholesterol or you have some bacon out there. It's not really going to change your LDL level, right? So I say to patients, it's okay to eat bacon. It's actually okay to do some of that, provided you're not carrying extra abdominal weight. Your liver makes these particles. An LDL particle is made up of a whole bunch of phospholipids, cholesterol, and on every LDL particle there's an ApoB. That's the protein at the top, the big yellow thing. ApoB I really like. It's cheaper than a full cholesterol profile. You save $5. The patient doesn't have to be fasting, and I think it's actually, personally, more predictive of future events. You take two people with the same LDL value, so I know this is an American slide, but these two people have the same LDL. But one of them's at lower risk than the other because their LDL particle size is bigger. So if you think every single LDL particle has an ApoB protein on it, if you measure the number of ApoBs, it tells you the size of the particle. So that person with the small particle size is actually at much higher risk. The guidelines, I'm going to go through these pretty quick because I want to actually talk about some of the drugs. I think that's the more important part. But we divide people into high, moderate, and low risk based on a Framingham risk score with all the limitations of that. You guys know this. High risk, they still say in the guidelines if you have diabetes, you're immediately considered high risk. That's fine. I think you are high risk, but our interventions have less effect on you if you're diabetic. And I won't go through all the specific targets. You guys all know these targets, and there are problems with these. Primary prevention goal. So I don't recommend targeting an LDL level. The guidelines are kind of mixed on that. They'll say drop it by 50%. All of the primary prevention trials looked at fixed doses of drugs. They didn't say if we get somebody to 3 versus 2 versus 4, who does better? And in fact, they actually, again, like I said earlier, showed it didn't really matter where you got the LDL. It didn't really matter where you were starting from. That fixed dose was what really gave them the benefit. So I'm not too worried about, you see that person with an LDL of 5, better recheck it, I got to make sure you really got it down, I got to get you under 2. Not at all. Primary prevention, fixed dose, same benefit. I would make an argument probably not lowering the LDL is really having all that much effect. It's all the other things that statins do. I would also say only use statins for primary prevention. If somebody does not have their cholesterol come down with a statin or they cannot tolerate the statin, that's it. I wouldn't use any other drug, and I'll show you why in a couple of minutes. The CCS guidelines do say maybe using some other agents, and we all know these agents, Fibrates, Ezetimibe, all these things. But they clearly state in the guideline there's absolutely no evidence for any of those agents. And there's actually some potential evidence of harm. So primary prevention, if somebody hasn't tolerated as a statin, no other drug. I wouldn't put them on anything else, contrary to what reps or anybody else says. There are several early primary prevention trials looking at medications other than statins where there was actually a significant increase, statistically significant increase in other causes of mortality. So again, if your patient doesn't tolerate a statin, that's it. Triglycerides, we often talk about triglycerides. Elevated triglycerides are associated with cardiovascular disease, but it's not clear if that relationship's causal or just something else. There's no data to say that lowering triglycerides really changes outcome. Now, it does if your triglycerides are over 10, because if you lower them when they're over 10, you get benefit in reducing pancreatitis, or if there's familial hypertriglyceridemia and your level's 40. But the person who comes into your office with a trig level of 4 or 5, yeah, they got to make some dietary changes, but it doesn't actually say, or there's no data to say if you lower their trigs with medication, you will affect outcome in any way. The reason why higher triglycerides may be associated with more cardiovascular death is that there's this inverse relationship between, this doesn't matter hugely, between the level of triglycerides and your LDL particle size. So the higher your trigs, the smaller on average your LDL particles are. So it may just be this linear relationship even though it doesn't have cause and effect. So how do we treat? I'm not going to go through all of the drugs, but we've talked a bit about statins. I want to talk about some of the other drugs that are mentioned in the guidelines. All sorts of studies out there. It's always hard to put all these things together, but I've tried to put things together a little bit to give you guys some info. Ezetimibe. I walked around to make sure that they weren't here at one of the booths. I would make an argument that this should rarely have ever be used. Trials have established that it lowers LDL by about 15%. There are no outcome trials. There's one trial called the SHARP trial that was done. They took people with chronic kidney disease, end-stage kidney disease, and they put them onto simvastatin and ezetimibe. They went onto both drugs, so it wasn't just looking at ezetimibe, or placebo. And they showed that there was a little bit of benefit. But how do you know if it was the simvastatin giving the benefit or the ezetimibe? They went on to two agents. Some of the early trials with this drug actually showed an increased risk of cancer. And then some of the later trials refuted that. But here's a drug where there's really no evidence, it's expensive, and just no outcome data, except in a trial where it's combined with another drug, a statin. Bile acid sequestrants, these are really poorly tolerated. Hardly any of us use these. They'll lower LDL, but again, no outcome data with these. And that's not just mortality data. You know, I know you're talking about the breast cancer mortality versus quality of life years and whatnot. These don't even have reduction in cardiac event data. Fibrates. Fibrates will lower triglycerides. They'll raise HDL levels. You guys know these, gemfibrozole, fenofibrate, clofibrate. When they're combined with statins, much higher chance of muscle toxicity. It's actually about 10 times the risk of myopathy compared to statin alone. About 5% of people who go on a statin and fibrate will get a myopathy. Pretty high numbers. With statin alone, tiny numbers. They raise your serum creatinine by about 10 to 20%. So if you see somebody's creatinine jump, don't be surprised. It can do that. Lots of trials looking at fibrates, good recent meta-analysis looking at 10 different randomized controlled trials, huge numbers of patients. There's actually a trend towards increased all-cause mortality when we use these drugs. It's not statistically significant, but definitely a trend to increasing mortality when we use fibrates. There's an increase in non-cardiac mortality, absolutely no effect on cardiovascular mortality. And this is lowering people's triglycerides that are really high. Now, lots of us do that, but we shouldn't do that. Similar findings in another meta-analysis. The metabolic syndrome patient, diabetic patients often have high triglycerides. Should we treat them? The field study actually just came out fairly recently, looking at about 10,000 people. These were people who had type 2 diabetes, and they were randomized to fenofibrate or placebo. There's people with high triglycerides. Trend towards lower coronary events, but it wasn't statistically significant. But there was a trend towards increased coronary death and all-cause mortality. We should not be using fibrates in people who are diabetics. Similar in the ACCORD-Lipid trial, showing no benefit. Nicotinic acid, niacin, raises HDL by about 35%. Nicotinic acid and nicotinamide are the two common forms. You see all the over-the-counter ones, they don't work at all. It's nicotinic acid that's what's effective, and the over-the-counter ones don't contain that. The AIM-HIGH trial actually just came out last year to see if there was truly benefit from using niacin. And well-done trial, 3,400 people. This was a prescription-based, long-acting form of niacin. These were people who had established disease, so very high-risk people. Those people with past MIs, low HDL, and they were already on a statin. So if you added in niacin, did you get additional benefit? Their HDL went up, their triglycerides went down, absolutely no clinical benefit. And the latest recommendations would say niacin doesn't have good effect. So it kind of goes right back to what I was saying at the start. If you really want to establish with your patient what's the risk, If you've established that they are at high risk and there's going to be benefit, statins really the only drug that there's been shown benefit. The other drugs, in fact, may cause harm without benefit. So, you know, I take issue with the Canadian Cardiovascular Society guidelines saying, well, and you read them, they say, well, you know, all these other drugs, you know, we don't know if they work. They make numbers better. We don't know if they actually change outcome, but we don't think there's any harm, so you might as well use them. That's kind of a crappy argument. So if people don't tolerate a statin, particularly for primary prevention, if you've really decided they need it, that's it. Wouldn't use anything else. And secondary prevention, really good evidence to treat, but the evidence is only for statin therapy, not the other agents. So I think that's it. I ran out of time, and I don't know if there's questions or... I'm sorry, a lot of information and numbers. But.
Could you just review the fixed doses for the primary prevention statins?
So review the fixed doses for primary prevention. So the first one was pravastatin at 40 milligrams a day. HPS looked at simvastatin at 40 milligrams a day. Jupiter looked at rosuvastatin at 20 milligrams a day. I think if you're going to put somebody for primary prevention on something, they're all generic now, right? So I don't think it really matters. I tend to either use simvastatin at 40 milligrams a day, rosuvastatin at 20 milligrams a day, or atorvastatin at 10 to 20 milligrams a day. You don't have to get people on really high doses for primary prevention at all.
I just want to clarify something. Is peripheral vascular disease still considered primary prevention or secondary prevention? I was told by someone else that it's sort of like a cardiac equivalent if you have peripheral vascular disease.
That was a really good question with peripheral vascular disease. You know, the earlier primary prevention trials included it as a risk factor. It was not deemed to be a cardiac equivalent. So you kind of have to go with what the trials say. Certainly somebody who has peripheral vascular disease, higher risk of having a cardiac event, but it's not this one-to-one risk, or it doesn't immediately make you as high risk as somebody who's had a myocardial infarct.
Thank you.
Excellent presentation, thank you. Question, I loved your bottom line about establish the patient's risk. Can you just speak about the confusion we have depending upon which calculator we use, what level of risk we get? Canadian Cardiovascular Society app, Framingham, sometimes we're getting low on the same patient where one is telling us the patient's high, and that really, really confuses us.
Oh, it's a really good question. What risk calculator do you use? You know, I actually made a risk calculator for the iPhone, and it died. It was a good learning experience, but it's hard to program something and wasted thousands of dollars. But you know, I think probably the best one to use is the Canadian Cardiovascular Society one. So if you, I think they've got it online as well, but it's available for, you know, iPhone, those sorts of things. There's one in UpToDate as well. I don't have a strong preference between using the Framingham data or the Reynolds risk score. So for those that haven't used the Reynolds risk score, it's very similar to Framingham, but it adds in a few additional features. You can put in family history, you can put in the C-reactive protein if you want. The key with those risk calculators is taking the number that churns out with a bit of a grain of salt, right? Because again, you know, look at Framingham. 80% of the women in Framingham that may be even deemed high risk don't fit into any studied criteria. So they'll help guide you. You got to go back to the art of medicine as well. I mean, there's your gestalt, right? I mean, the person who's got the really strong family history, who's clearly got a crappy lifestyle, who, you know, you just have that sense they're at higher risk. Now, I know that's not evidence-based, but the evidence that we use is pretty weak too.
Just a quick question on stopping statins in both populations where they may have been put on it as when they weren't necessarily high risk but have been on it now for a long time, and also in the elderly. When would you think of stopping?
Oh, really good question. When do you stop statin therapy? You know, people get onto drugs and we often don't really step back and evaluate when to take them off. You know, I don't. There really are not good trials looking at the very elderly being on statins. So somebody who's, if they're not really high risk because they've just had an infarct or something like that, you know, when you're getting into your 80s, are you really getting benefit? Probably not. Certainly nobody can quote you a trial to say that there is benefit. Somebody where they maybe were put on it inappropriately. So, I mean, I'll have people come to the office that, you know, they're on a statin, and you think, well, why'd you, well, you know, because I have hypertension, I was told that I'm high risk, I have to be on this. Well, somebody with treated hypertension, I mean, look at the primary prevention trials, your benefit's so marginal there. So stepping back with that patient and saying, okay, well, you have hypertension, you don't have any other risks, so probably in you got to keep taking this drug for 5 to 10 years for an absolute risk reduction of what, 0.3%? Pretty small number. So having that conversation with the patient again to see if they really want to keep it going. There's nothing wrong with reevaluating drugs. I mean, when we get people on something, they don't have to be on it forever and ever.
I have that's loud. 2 questions. Your thoughts on CoQ10 as an addition to statin, and then the use of red rice yeast instead of a statin.
Well, good questions. CoQ10 is certainly helpful for people who get some muscle aches and pains with a statin. Can certainly reduce those muscle aches and pains. There's not real outcome data with CoQ10 to say that it's helpful in reducing cardiac events or anything like that. Red rice, I don't know, to be honest. I know it'll make numbers look a little bit better. I haven't even seen any sort of small-scale observational trials or anything like that, so I don't know if anybody else knows, but I haven't seen anything well done with that to say that we should be recommending it. It's interesting when you talk about CoQ10 and muscle aches and pains, because you'll get some people where they say, oh, I'm getting some muscle aches and pains. I know, I've got to finish. You know, when you think about what you're actually trying to prevent or what leads to a cardiovascular event, it's inflammation. So if you take 100 people and you say, we're reducing your risk, or we've reduced your risk by 3%, that may mean that 6 people didn't have a heart attack, but 3 people did, if that makes sense. So when we use drugs where you may get some aches and pains, you're creating some inflammation, and are the people that are getting some aches and pains maybe not getting benefit from the statin? Maybe they're getting harm. So you got to really question that too. I know that's a bit confusing, but I'm probably done, right? That's it. Okay, well, thank you.